Hi, everyone. Welcome to another exciting year of EMS protocol and policy updates. I'm Dr. Jenny Farah, Base Hospital Medical Director for UCSD, as well as the Medical Director for the Chula Vista Fire Department. I've been doing this a lot of years, and I have to say, don't want to jinx myself. Relative to other years, this really won't be that bad. I don't think this is going to be some 90-minute plus marathon like in years past. We have no new medications, no new procedures or scoring systems. So I think it's going to be a much more tolerable year to get through, thank God. And I have to say, if I were to give this protocol update a theme, I think this is a year of synthesis. I think this is a year where the county did a great job of noticing where certain concepts were perhaps scattered throughout the protocols, and they thought best to house it under one area with clear, concise language where it doesn't conflict with anything else. I also saw this as a year where they took the tenets of previous county memos that have been released or tenets from PAC Pearls from the Pre-Hospital Audit Committee and officially protocolized them. So took what was mentioned there and officially put it into protocols, which certainly makes it easier to follow and reference later. So a big shout out to County EMS, particularly Mike Asoff, who put together a great protocol and policy update packet, which I encourage you all to go to the county website and check out. Not only will you find a PowerPoint, much like the one I'm going to use here, but they also release things like changelog and other materials that make it easier to follow to sort of see all the different updates. This will not be 100% comprehensive of what's included in that packet. That's why I encourage you to look at it. However, I did try to focus on what I believe are the highest yield topics. And with that, you'll notice that this PowerPoint, although probably 90% plus of the content is taken from the county release PowerPoint, I sort of mixed and matched and sliced and diced it as I saw fit to focus on what I thought was the most important for you all. So brief overview of the adult protocols. We can expect to see some updates and that we'll take a closer look at, as well as the pediatric ones. And we'll start off easy. We'll start with things that are global throughout all protocols and policies. You'll notice that EKG has been updated to ECG, so going from the German version to American English, so you'll see that reference there. Also, the removal of PRN from capnography. There's a lot of areas in our protocols where it would say capnography PRN. That's since been removed. Also, you may not have noticed this in years past, but there are many footnotes throughout our protocols that reference state regulations. And those state regulations underwent a rechaptering recently. So too, our footnotes and our citations to those have been updated as well to reflect that. Abbreviation list, central nervous system's been added, left ventricular assist device, torsade de points. I think it's French. I don't know. We had German, now we have French. I took Spanish in high school. I cannot help you with that. But I do know that torsades de points is the EKG finding you usually see or classically see in digoxin poisoning. So that abbreviation's been added to the list. Okay, like I said before, I have mixed and matched this PowerPoint. So I front loaded this with what I believe to be the highest yield material. And it'll be a little bit going from protocols to skills lists and other things. But again, just wanted to sort of front load you all with what I thought was the most important. Okay, so you may have remembered from last year, we introduced a lot more specific guidance on base hospital physician medical direction. Most notably, last year is where we introduced the idea of emergency protocol exceptions, or EPEs. That was housed under a protocol, which at the time was named protocol standards. It's since been renamed patient management standards. And that first part of the protocol, which you see to the left of your screen, is still there. And it now comprises the first part of this new patient management standards protocol, or renamed protocol, I should say. And the second part is going to dive into the details of when BLS or ALS should transport. So a renaming of an existing protocol. The first part of it is something you've seen before, and we'll of course take a look at that part too that has to do with BLS versus ALS for transport. So looking at that first part, that 100.1, again, should be familiar to you. This was released a year ago, and it had to do with sort of the confines of how a base hospital physician's medical director, where it can exist in. So certainly advocated for things like staying within a provider's scope and not ordering things that are outside of a local optional scope of practice protocol. And most notably, this is kind of the first time we use language like not authorized. And even though this isn't new, I think it'd be good to just take a beat and remember that the two things in our protocols that are not authorized are ketamine at sedative doses and Narcan at cardiac arrest. We've had this language in our EPEs infused into our protocols for a year now, and we've seen sort of the case review that's come out of that. And I can tell you, I've seen Narcan ordered for cardiac arrest from physicians, and so we've had to go back and give feedback to those folks. So this is just a gentle reminder that all parties involved need to be mindful of what's not authorized, meaning The medic should not be asking for these things, and MICN should not be getting a physician to review these orders, and certainly a physician should not be granting these orders. And understandably, sometimes the communication pathway works in the opposite direction where nobody's asking for it, but the physician says, I want you to give Narcan during a cardiac arrest where perhaps they were asked to just review it for termination. So gentle reminder, these are the two things not authorized. It should not be asked for. And this still is in our protocols, just renamed patient management standards and under that first part of it. So let's take a look at the second part. And this is in reflection of kind of like what I said before, that year of synthesis. So you might remember a year or so ago, the county released a memo called Patient-Centered Care Modification, or PCCM. And it had to do with when it was more appropriate for BLS versus ALS to transport a patient. And now this has been officially put into our protocols in the protocol you see ahead of you, 100.2. And we're actually going to take a look at this line by line because I believe it's very important. So this is going to outline, if you start at the top with standards, patients meeting the following criteria shall be transported by ALS. Now, of course, there's a little note there. Exceptions. BLS transport may be considered under the following conditions: an MCI or an Annex D activation, ALS resources not available within a reasonable time frame, and they don't quantify that, so we'll talk about that in a bit. Or if it's a hospital-to-hospital interfacility transfer, meeting criteria for EMT scope of practice, or existing medical devices, which we're going to look at the latter in just a beat here, those would be exceptions where BLS could transport. Now, I have to say, as a medical director, when I see reasonable time frame, I think this is going to do with a lot of factors. I think this is going to do with what's the patient's physiology. Is this someone who needs ready access to hospital resources more than anything else? What is your ETA for ALS showing up? And is your hospital closer than the time it would be to wait for that ALS unit to arrive? These are all things that a BLS unit will be asked to deliberate. And of course, we're encouraging them to contact the base so they can help them through that. But it's not prescriptive. It's not telling you what reasonable time frame means. So just advocating to all the EMTs out there, make sure that you're weighing physiology of the patient, what's your closest appropriate hospital, how far out is that ALS unit, and taking that all into consideration. So we're going to now look at the bulk of what shall be transported by ALS. A decompensating patient. So this is someone who appears to be an extremis, new altered mental status, poor appearance, poor perfusion, airway issues, everything you're seeing there. Speaking of airway, if there's any current or anticipated need for airway management, someone who should be transported by ALS. If they're tachypnic, hypoxic, or if they're requiring, adjuncts, so like airway adjunct devices, certainly someone best suited for an ALS transport. If they're having cardiac chest pain or an anginal equivalent, if their EKG showing signs of ischemia or infarction, a new dysrhythmia, any anticipated needs for IV fluids or vasopressors, of course, that's all within ALS scope, and any hypotension. Disability, any acute change in mental status, a new neurologic deficit, so beyond their baseline if they have existing deficits, seizures or multiple seizures like a status patient, acute agitation, or severe intoxication or overdose. Now, under the miscellaneous category, worth sort of focusing our efforts on here. So anyone meeting T460A, including special considerations designated for transport to a trauma center. So if you're going to a trauma center, whether it's with a major trauma victim or someone under the banner of special considerations, should be transported by ALS. Any ALS medications administered, except a single therapeutic dose of naloxone, ondansetron, glucagon, dextrose, or acetaminophen, and are not anticipated to need repeat doses. So if a crew just gave one therapeutic dose of acetaminophen, for example, and it's completed, that patient, and barring, they don't meet any other requirements that you see here, that patient could go via BLS. Any hypoglycemia with persistent altered mental status or hyperglycemia with persistent altered mental status, that's someone who should be transported via ALS. Pediatric patients with a high risk complaint, such as a BRUI. So this is important because we're actually going to take a look at that brief resolved unexplained event protocol under pediatrics. Previously, there's been language in there that designates when BLS can transport versus ALS. That's all been removed because, as you can see here, it's advocating for the universal use of an ALS transport for those patients. And we'll take a look at that protocol in just a sec. EMT provider has clinical concern. I'm going to highlight this because I think this is where we all need to take a moment to all understand that if at any point in time an EMT says, I am not comfortable transporting this patient, that needs to be listened to, that needs to be acknowledged. And I want every EMT out there to feel comfortable expressing that. Even if a patient, let's say, technically meets this criteria for BLS to transport, if that EMT is anticipating that the patient may need more advanced care en route than what is within their scope of practice, we need to listen to that and respect that and have that patient transported with the assistance of a medic. So just want to take a beat on this because it is in there for a reason. This caveat of EMT provider has a clinical concern. And, this is going to be one of those things, much like the addition of EPE and non-authorized medications on the slide before. This might be one of those things that after a year or so of seeing cases come through and it going through our quality improvement process, we'll reflect on things that we can modify on this protocol to see what's most appropriate for patients. So great example of synthesis. This is where that PCCM memo has now been officially put into protocol. And I look forward to seeing sort of how this manifests in the year to come. And just to help you out with those transport decisions, this is just a nice algorithm that complements S100.2. So let's say you have a transport and BLS is the only one on scene. Review the transport criteria above and complete the PCR with documentation of criteria. So they're talking about the S102 criteria that we just looked at. It should be sort of documented what you're following along with. If none of those criteria are met, meaning that it's not mandated that ALS needs to transport, then it's acceptable to have BLS transport that patient. If any of the criteria are met, then that BLS unit should be requesting an ALS response and following that PCCM, modifying that criteria we spoke about, and then provide turnover to that ALS resource. And the ALS personnel should not have BLS personnel transport. Consider contacting the base hospital for additional assistance. So this is something where if that ALS unit comes on scene, conversation takes place, you can always incorporate the base for guidance as well. If an ALS resource is not available within a reasonable time frame, so the BLS unit there acknowledges that criteria were met for an ALS unit to have to transport. They reach out, they figure out that the ETA is actually going to exceed what's probably reasonable for this patient, then they can consider BLS transport to be, the most appropriate to get them to the closest facility. And of course, base hospital contact would be encouraged in a circumstance like this because it would be rather tricky, right? So this is getting into that little citation at the bottom of the protocol where it says that the ALS unit is not to be expected within a reasonable time frame. That's what this is in regards to. So if that were to happen, again, consider all the factors involved. I'm speaking to the EMTs out there and allow the base to help you with this decision so that you have a better understanding of what's your closest receiving and what sort of time you're looking at, whether you wait for ALS or go ahead and transport. Let's say BLS and ALS are already on scene together. Still review that criteria, take a look at what's most appropriate. If any criteria are met, then the paramedic should attend to patient transport or transfer care in an ALS ambulance. So medic can hop on board with the BLS unit or just transport them via ALS. If no criteria are met, it would be acceptable to have the BLS ambulance go ahead and transport this patient. So these are pathways for either BLS or ALS transport, regardless of whether both were on scene to begin with or it was only BLS. And this is the complement to the S102 that we saw on the previous slide. So hopefully this will be posted up in every base. I want all the medics and EMTs, of course, to review this as well. And really not too much new content, because again, this is really just a protocolization of the PCCM that was released in a previous county memo, but important, very important and easier to reference for our case review moving forward. All right, trauma. This one got a revamp. This is very exciting. I want to highlight this. And this is the first time I've done a video embedded in slides. So hopefully I'm not covering any content and I don't think I know how to point to things. So we'll just forget about that. This is a big deal. Just focus. Okay, so new additions both for adult and peds. Ondansetron or Zofran is being added for the treatment of nausea and vomiting. Now there's a mention of giving a normal saline fluids or lactated ringer solution when appropriate for these traumatic cardiac arrest patients, and not administering epinephrine. So we kind of mix between trauma patient and cardiac arrest, but for the general trauma patient, Zofran has now been added for the treatment of nausea and vomiting. For traumatic cardiac arrest, it is now going to be put into standing order to go ahead and give fluids, a fluid bolus, and we are not going to administer epinephrine. This is different, right? We've previously not said not to administer epinephrine. Now we're saying do not administer epinephrine for your traumatic cardiac arrest. It's a very similar theme in pediatrics. We're also going to take a look at a whole new flow chart for the treatment of cardiac arrest for our patients for traumatic cardiac arrest. Pediatrics, same thing, ondansetron, but per the drug chart. Also, same things regarding fluids, just per the drug chart, but similar to adults, do not administer epinephrine. And we're going to take a look at a brand new traumatic cardiac arrest flow chart for both adults and peds. So big step back for trauma patients. You can now give Zofran for nausea and vomiting, but do note if the person actually vomited, that might be information that the hospital will find worthwhile. Go ahead and give fluids if you've got a traumatic cardiac arrest, and do not administer epinephrine. Okay, this is new. This is some newness. So just a reminder there. And the flow sheet I'm going to show you for both adult and peds also nicely itemizes sort of the decision-making process. So this is for adult traumatic cardiac arrest. It has a little pivot here in the event that it's actually not a traumatic cardiac arrest, and then it goes into our medical arrest protocols. But assuming you're dealing with a traumatic cardiac arrest, first make sure that the patient meets pre-hospital determination of death, which is an S402, or the initial rhythm of asystole and no signs of life, which is sort of a part of S402. So S402 under pre-hospital determination of death includes, no spontaneous signs of life. What it also includes, and it's important to remind ourselves here, it also mentions ensure that the mechanism of injury aligns with their mechanism of illness, meaning make sure this truly is a traumatic cardiac arrest and not a medical arrest that perhaps was mislabeled as traumatic because there was some associated trauma. So if you have a patient that meets that S402 definition of pre-hospital termination death, or you have discovered they're in asystole with no signs of life, you do not have to initiate any resuscitative efforts. And keep in mind, this is not delineating between penetrating or blunt. This is all traumatic cardiac arrest. So we now have a pathway of do not resuscitate as outlined here. Let's say they don't meet these criteria and you're under no. Go ahead and initiate resuscitative efforts, meaning CPR, hemorrhage control, like if you have to put on a tourniquet, ventilate with capnography or any airway adjunct devices you need, do a needle thoracostomy if you're suspicious for a pneumothorax, and then ask the questions of people on scene if you can. Was this witnessed by anyone? And then with this protocol, it says cardiac arrest witnessed by first responder. So this is someone where you're on scene already treating and they arrest in front of you. Or you get ROSC at any time during your resuscitation, or you start to see signs of life like spontaneous movement or breathing, or your anticipated transport time has to be within 20 minutes. If the answer to any of those things is yes, then we encourage rapid transport to a trauma center, and you want to sort of pack up and go as soon as you can off scene. And another reminder to not administer epinephrine, already housed in the protocol before, the page before, but mentioned here as well. So if you have come upon the scene, patient does not meet S402, they're not in asystole, and they seem to have signs of life, you're going to go ahead and initiate resuscitation. And parameters for that are here, not parameters, but guidance. If you did not witness them going into cardiac arrest, or they never achieved ROSC, or you're not seeing any signs of life, and the answer to all those questions are no, then you can contact the base hospital to consider getting a termination resuscitated order by the physician. So important thing to note, this is going to replace all trauma-related TOR language that you previously saw. I say that because previously in protocols, there was mentionings of, consider a BHPO for termination for blunt trauma and all these other things. That's all gone because everything is here now. So any other mention of when you can terminate resuscitation in a traumatic cardiac arrest has since been removed or revised, and everything is in reflection of what you see right in front of you now. So this is going to perhaps open the door a bit for some more termination orders, or just allowing the medic to not initiate any resuscitation at all if you sort of default into this pathway. But it certainly is going to be different. Now, whether it's blunt or penetrating trauma, we now have some guidance for when you should initiate transport right away because you're going to go to the trauma center, or stay on scene and resuscitate. And with that, what criteria need to be met to terminate on scene. I think a lot of fanfare is going to focus on this assess. I think there's going to be some circumstances where you're always going to be outside of that 20-minute window, and that's going to need to be considered. That's why I think it's important sort of earlier on the timeline. If you're forecasting, you might be stuck in this predicament here, to sort of mobilize for that or call the base, see what your closest trauma center is to begin with, so that you're not running up against time because it took that long to sort of get to this part of the pathway. So I'm encouraging all the medics out there, as soon as you're on scene, and if you already know that you're probably outside 20 minutes of a trauma center, to just quickly do this assessment, know which direction you're going. Are you going to load and go, or are you going to stay on scene and do your resuscitation? And like everything else that's new this year, we're going to take a look at these cases throughout the next year and see if this needs to be modified at all, or if it's appropriately selecting patients who likely did not have a chance at meaningful neurologic outcome, which is what we're always aiming to do when it comes to our cardiac arrest pre-hospital protocols. For pediatrics, it looks very similar, although a little bit different. So this is the traumatic cardiac arrest algorithm for pediatrics. Again, if it's a non-traumatic source of the cardiac arrest, pivot to that protocol. But assuming it's traumatic in origin, if the patient meets obvious death criteria or S402, again, that pre-hospital termination of death, answer is yes, you don't have to resuscitate. If the answer is no, just like adults, you're going to initiate CPR, do hemorrhage control, defibrillate where appropriate, ventilate, do a needle T if you suspect a pneumothorax. And then this is actually recommending for rapid transport to the trauma center. So that caveat of time to trauma center is not relevant here. You're going to go ahead and transport. And again, do not administer epinephrine because we're not doing that for traumatic cardiac arrest moving forward. So slightly different than the adult one, with the main difference being sort of what you see housed here under yes or no. So likely going to lead to perhaps more transfers of our pediatric, but thankfully this isn't a common circumstance. So hopefully we won't be seeing that too much. But a lot of newness. This is why I wanted to front load it. This is one of the moments to sort of take a beat and reflect that, we now have cardiac arrest management protocols for trauma that are not taking into consideration blunt versus penetrating. It's going to include all of them. And there are pathways where medics can pronounce on scene without having to initiate any resuscitation, or considering getting a BHPO to go ahead and terminate resuscitation if you fall to this part of the pathway. Exciting. Okay, now on to something a little bit different, a little less high stakes, shall we say. But you probably all know that under the hemodialysis patient protocol, there's treatment for hyperkalemia. Some of the language has been updated for suspected hyperkalemia. Now it specifies peak T waves or widening QRS complex. That's what you might see on your EKG with someone with hyperkalemia. And the calcium chloride dose has been updated from 500 milligrams to a gram. What's notable on this, and what we saw in case review this last year, is, there's a lot of patients who may not be on hemodialysis, but they could still be at risk of having hyperkalemia. They could still have kidney failure. They could be on peritoneal dialysis. They could have started new medication that puts them at risk for hyperkalemia. Nonetheless, we realized that it probably would help if we had some treatment pathways for patients who, okay, maybe they're not on hemodialysis, but we still think based on their EKG, they could have hyperkalemia. So now there's an addition on this protocol language that you sort of see here, that for patients not on hemodialysis with suspected hyperkalemia, of course, get that 12 leads to look for those peak T waves or widening QRS. And then if you're concerned enough where you might want to initiate treatment, go ahead and contact the base. We would still like for these cases to have the review of a nurse, a physician, to sort of discuss it out loud, see what other treatment options there could be. But certainly if the medic's concerned for hyperkalemia and the patient is not a hemodialysis patient, we do encourage them to call the base if after they've gotten that EKG, they're worried enough where they might like to give calcium. So it's mentioned here. This is a direct reflection of what came out of PAC, again, getting back to that synthesis here. And a quick note on those EKG findings. So when we say peak T waves, what we mean is that the morphology of the T wave is very pointed. And then what could also happen before you even see QRS widening, you might start to see flattening of that P wave. And then, of course, as the hyperkalemia gets worse and worse, that's where we see the stretching of the QRS to the point where you just become a sine wave. So that's very advanced hyperkalemia and very concerning. And your patient's likely going to be quite symptomatic from this. So please keep in mind, if you have someone on hemodialysis or at risk for kidney injury, at risk for hyperkalemia, 12 leads a great way to sort of assess, is this happening to the point where they may require medication? And speaking of that medication, calcium chloride, we mentioned previously how the dose for that protocol is going to go from 500 milligrams to a gram, but that's quite universal now. So in other protocols like PEA or crush injury requiring extrication with compression of extremity or torso greater than 2 hours, or for suspected calcium channel blocker overdose, that dose is also going from 500 to 1 gram. And it's removing the repeat dose, which makes sense because instead of giving 500 milligrams twice, you're just going to give the gram at one time. I think this is going to be nice because when the hospital says an amp of calcium, usually what that's referencing is a gram. So I think the language will translate easier now when perhaps the base is telling you to give a gram of calcium or an amp of calcium, that dosage will align better with what the medics are doing anyways. So calcium chloride will now be administered as a gram. And for many protocols, the repeat dose has been eliminated because you're giving it all at once. But don't worry, it's not just calcium having a moment this year. Midazolam is also getting some extra special attention. So under the respiratory distress protocol, midazolam, there's now an addition that if the patient's unable to tolerate CPAP, go ahead and give them midazolam at a little dose, 0.5 to 1 milligram to help them calm down. Same thing if you have an intubated patient with agitation and a potential for airway compromise because of that. There's now a mentioning of midazolam and the allowance of going ahead and giving that medication. This was added too because language like this is also in the pre-existing devices protocol. But now this is clearly saying that if you yourself are intubating, so if the crew intubates and later on the patient becomes agitated, you can give Versed. Just like if you inherited a patient that was already intubated and they became agitated, you can go ahead and give them midazolam. So midazolam now being added for agitation, whether that patient's on CPAP or intubated. Burn, slight adjustment here. Burn center criteria, circumferential burn or burn to face, hands, feet, and perineum. I think adding that burn was just a way to clarify things. And the definition of high voltage has now been changed from 120 volts to greater than 1,000. And this was at the request of our burn center at UCSD so that it would be better reflect national guidelines on what the Burns Association considers a high voltage injury. And most household voltages are around 120, 240. So likely, these high voltages will be an occupational exposure. And just know that unless that voltage was 1,000 volts or greater, you won't necessarily have to go to a burn center. You could still call the base and see what the best avenue is for the patient. But again, that burn center criteria and protocol will now be limited to 1,000 volts or more, which will, necessitate having to go to the burn center. And it's the same for peds. So I'm not going to show you the protocol for peds, but just a reminder that this update here of 1,000 volts is applicable to the peds burn protocol as well. Skills list. So again, jumping around a little bit from protocols to skills list, but it's important stuff. So new requirements for end-tidal CO2. Now, this is one of those examples where commentary on end-tidal use and sort of assessment of airways before or after intubation was spoken of differently amongst some different protocols. This is now just a nice common area where we could talk about end-tidal CO2 and what to do when you're intubating a patient. So we'll take this line by line because it's really important. So the presence of an end-tidal CO2 greater than 0 is required prior to endotracheal intubation or paralaryngeal airway adjuncts, so retroglottic or supraglottic airway placement. If the assessment rules out an airway obstruction, but the end tidal remains 0 despite effective BVM, including with an OPA or NPA in place, a PAA may be placed. So you can go ahead and place one of those paralaryngeal airway adjuncts. For patients with intractable vomiting or airway bleeding, initial management should focus on clearing the airway with patient positioning, so log rolling off to the side, and clearing out their mouth and oropharynx with suctioning. Immediately following insertion of advanced airway, persistent end tidal waveform and reading other than 0 must be maintained or that tube has to be removed. Okay, so a lot of this we've seen before, right? You need the waveform and that number beforehand. You need to make sure it doesn't drop to 0 after you've placed your instrumentation. And now there's, some further language. If the end tidal drops to 0 and does not increase with immediate troubleshooting. So of course, make sure your connections are okay. Don't just reflexively pull out the tube. See if maybe you can identify why that value is still at 0. But if after your troubleshooting, you've come up short with an understanding as to why it's 0, you are asked to extubate the patient and then manually ventilate them with the BVM. Continuous capnography monitoring after end tidal or PA insertion, after endotracheal tube insertion or PA insertion is required. Report and document at a minimum the capnography value, the waveform, absence of abdominal sounds, presence of lung sounds before and after advanced airway placement, which I know you're all doing already, and at each patient movement and at transfer of care. This is my call out to all the crews out there. Make sure when you roll into that emergency department with an intubated patient, you're documenting, keeping note of what is on that monitor in terms of values and waveforms before you transfer them off of your gurney onto the emergency department's gurney. Better yet, have the physician confirm placement of the tube before you physically move them. It's at those places of movement that we see a lot of dislodgement, and your monitor data is usually the thing that sort of protects you in that everyone best understands what the status of that tube was before the patient was moved. So please keep in mind and document this accordingly. And then when moving intubated patient, apply a C-collar prior to moving to minimize head movement and potential dislodgement. So again, those transfers of care, high risk area for tube dislodgement, in addition to stabilizing the head and neck, Also, make sure your monitor is there and you're clocking the data that's rolling in prior to your movement. And then once you move them over and it's perhaps that patient's now attached to the emergency department's equipment, logging what you see there as well, making sure everyone's on the same page and that patient stays safe and that tube stays in place. And that this is important to note because any previous language about end tidal or guidelines before and after any insertion of an airway adjunct, this is sort of like nicely housing it. It's clear other mentionings of airway management or guidance like this has since been removed. Speaking of, one thing that was removed was able to adequately ventilate with BVM. This used to be housed under contraindications to intubating or placing a PAA. So this is notable, right? It used to say if you were able to adequately ventilate with BVM, it was a contraindication of that. I think the county has since realized that there are a lot of good indications to intubate someone, even if you're adequately ventilating them. Perhaps you have a really long transport ahead of you. And so certainly they didn't want to limit a medic's ability to go ahead and intubate if that was the case. So able to adequately ventilate with BVM, no longer contraindication to either place an endotracheal tube or one of those PAAs. And like I said previously, all the language that had to do with end tidal and all those pre-measures has since been removed because what we saw on the previous screen has essentially replaced it. Exciting is that CPAP has now been authorized for EMTs and advanced EMTs to do in our system. Now, they can't initiate it per se, but certainly if they're on scene and CPAP is started by a medic, or perhaps it's an existing device, like they're doing an IFT and the patient's already on CPAP, our EMTs and advanced EMTs can now go ahead and continue onward in transport with that in place. They can continue on with the skill. They just can't initiate it. There's also been some added language for 12 lead indications, just to better capture who might be at risk for some type of cardiac ischemia or arrhythmia. There's language now added of chest discomfort / pain, and then some qualifiers of dyspnea, upper abdominal pain, fatigue, which is a great way to remember that not everyone has the classic left-sided chest crushing pain, causing nausea and sweating. Some people might manifest their ischemic cardiac injury with upper abdominal pain or nausea or just a lot of fatigue. And adding those little qualifiers is just helpful to remind everyone out there what those symptoms could be. Same thing with arrhythmias. A lot of patients don't say I'm having symptoms of an arrhythmia. They'll usually say, I almost passed out or I'm having palpitations. That's usually the language that's expressed. So having that added under the skills list is just a helpful way to remind everyone when to go ahead and maybe apply that EKG. External cardiac pacing, a little bit more instructions on how to do it. I think a lot of crews are doing this already, but it's just nice to sort of go back to it, make sure we're all on the same page. So guidance for pacing, it's going to be set rate and energy per manufacturer's recommendation. Increase that energy setting until capture occurs, which is usually between 50 and 100 milliamps. After electrical and mechanical capture is achieved, increase your energy by 10%. And if the patient remains hypotensive, increase the rate by 5 beats per minute, not to exceed 100. I don't know who's pacing over 100 beats per minute anyways, but don't exceed 100 to achieve and maintain adequate perfusion. So some guidance there on pacing. When we look at the bradycardia protocol, you'll see where that's how that looks on the actual protocol, but this is the guidance that will be in the skills list as well. Skills list, a little bit of etc. So length-based resuscitation tape. They've since removed the mentioning that children 37 kilograms or over to go ahead and use adult medications. They've removed that because now on the turquoise page of P117, it's been updated to provide specific dosage recommendations for children who are over, or pediatric patients who are over 36 kilograms. So no longer are we saying pivot to adult doses. There's actually very specific guidance on what to do with a pediatric patient who weighs 37 kilograms or over. Under IOs, advanced EMTs are now authorized to establish and maintain an IO in a pediatric patient only. And I know we don't have a ton of advanced EMTs in our system, but for the ones that we do, they now can go ahead and place and maintain an intraosseous line in a pediatric patient. Medications list, nothing new. It's really just some formatting revisions. They're now going to put each medication on a single page with the class and the mechanism and the indications, and it'll just be easier to reference because it's a single page for each medication. It's a little bit of a formatting revamp, but again, no new medications. Under the ALS pediatric drug chart, under the grade pink portion, they updated the NG tube size to 5 to 8. So it's now recommended to have a wider range of nasogastric tubes for patients who fall on the grade of pink side. Atropine was also given an update in the concentration. Instead of 8 milligrams and 10 mLs of fluid, it's now 8 milligrams and 20 mLs. All right, now flipping back to protocols. So chest pain or discomfort, right? Because we added discomfort slash pain of suspected cardiac origin. Under ALS, if the SVP is over 100, it's now going to recommend to treat the pain with opioids. So just highlighting how opioids are likely a better measure than other pain medications that we have in our toolkit if you're worried about a cardiac source for their pain. Under pain management, I'm so excited about this. You might recall there was this whole section of like BHPO, like indications, like if the patient met one of these, you needed a BHPO to give them pain medicine. That's all been removed. So now no longer do you need a base hospital physician order to treat a patient's pain if they have isolated head injury, severe headache, drug or alcohol intoxication, or suspected active labor. You no longer need a base hospital physician order to give pain medications. So that's been removed. And it's the same for peds. It's been removed from there as well. They also removed needing a base hospital order for our repeat doses of fentanyl and morphine. So fentanyl, that third dose that previously required a BHO for the intranasal dosing, now no longer need that. Same thing with morphine for the repeat doses. You just no longer need a base hospital order. The dosage guidelines, like what they recommend to give, is still there, but not needing that base hospital order. That's since been removed. So again, we removed the need for a BHPO to give pain meds altogether. And where it used to say BHO for those repeat doses of fentanyl and morphine that you see right there on the screen, now no longer. So much more is on standing order. For ketamine, it used to say slow drip, right? It didn't really quantify what that meant. Now for not only ketamine, but for also amiodarone and TXA, it now clearly says put the dose in 100 mLs of NS and you're going to run that over 10 minutes. So now the language is much clearer on what it means to do a slow IV drip. It's clearly saying put it in a 100 ml solution and you're going to run that over 10 minutes, not just for ketamine, but for amiodarone and TXA. Under CPR arrhythmias, unstable bradycardia, we already went over this, but those guidelines for how to initiate that external cardiac pacing, this is just what it looks like on the bradycardia protocol. So you see it here, but it's exactly what we reviewed when we were talking about the skills list. Also revised under CPR arrhythmias protocol under ventricular tachycardia and adjunct cardiac devices, they updated the dosing intervals for lidocaine. So previously it used to say to give 1.5 mg per kg IV or IO over, every Q to 8 to 10 minutes. Now you can go ahead and give it at intervals every 5 minutes. So the dose is the same, but the intervals in between have now been shortened to you can give repeat doses every 5 minutes as long as you stay under the maximum of 3 milligrams per kg. And it's much clearer than trying to say every 8 to 10 minutes. For VFib and pulseless VTAC, just a comment about, go ahead and give epinephrine as you already do, but begin it after the second defibrillation. And this is a great way to ensure that we're focusing on the most meaningful intervention, which is that defibrillation. And it's not saying don't give epinephrine for these patients. It's just saying focus on that first defibrillation, the second one, and once the second one's delivered, to go ahead and administer that epinephrine. So a better reflection of some national guidelines and, again, kind of focusing the efforts on what's most important, which is defibrillate that patient. And it's the same for peds. Existing devices and medications, not a new protocol, we've certainly seen this, but some updated language. So now it will say paramedics may assist patient or a surrogate with the administration of emergency medications prescribed for self-administration with a base hospital order. So this is a nice way to acknowledge that some patients may not be managing their own injections. It could be a caregiver or family member. So now it's allowing for medics to assist that surrogate with administering these medications as well. The example typically given are patients who might need some type of IV steroid or IM steroid injection if they're in an adrenal crisis, for example. And so those recommendations are still all the same. It's just now going to acknowledge that it might be a surrogate that's on scene who you'll be assisting these medications with. Under alter neurologic function, S123, they removed with the diabetic history from the symptomatic hyperglycemia indication. And this is acknowledging that, not all patients have been diagnosed with diabetes just yet. But if you have someone with polydipsia, polyuria, extreme fatigue, and you're concerned about that their hyperglycemic state could be contributing, you no longer have to have a history of diabetes to move forward with treatment. Much like the state regs rechaptering, this might not have been as high on your radar. I know it certainly wasn't for me, but we have a ChemPact deployment protocol that mainly has to do with the treatment of organophosphate poisoning. And they simply updated the language and to be more comprehensive and accurate with the ChemPack cache inventory. Again, maybe not something at the top of your, on your radar, but just to be mindful of that protocol update too. Under respiratory distress, and now we're looking at our pediatric protocols, advanced EMTs are now authorized to administer nebulized epinephrine. Under BRUI, and you might remember I told you to keep this in mind when we looked at that S100.2 or BLS versus ALS for transport, the language in the BRUI protocol has been updated as well. So previously there was language that designated when BLS could transport versus ALS. That's since all been deleted because now there's that bullet point in S102 that says for high-risk pediatric patient, like someone who's had a brief resolved unexplained event, they should be transported via ALS. So too, all the language that says otherwise in S172 has been removed. Under pain management, we talked about this a little bit with the adult pain management. They removed all those BHPO indications, much like we saw previously. Also added a footnote that if a patient refuses or has contraindications to acetaminophen, you can treat as moderate pain, meaning you can go ahead and give fentanyl or another medication. Format updated for treatment of moderate or severe pain to be consistent with the adult pain management protocol. And this will make more sense when we look at the next slide. A lot of that has to do with guidance on repeat dosage. And this is very much in reflection to what we saw in the last year or so with case review and what came out in the county memo. We realized that there wasn't a lot of clear guidance on repeat doses of pediatric pain medications, and that the length-based resuscitation kind of wasn't enough in guidance on dosages, let alone repeat ones. So now you'll notice under S173 for moderate pain for both fentanyl IV and fentanyl IN, it's going to advise for the IV dosing that if you're going to give a repeat dose, you're going to do that at half the initial dose. So for IV, your repeat dosages are going to be half the initial. For intranasal, it's just going to be at that same initial dose. So now we have specific guidance on repeat doses of fentanyl, both IV and IN, with the difference being your repeat dose for the IV will be half your initial versus the repeat dose for your intranasal will be go ahead and do that same initial dose a second time. BHOs are still there, but now we have very clear guidance on those repeat doses of pain medications in pediatric patients. BLS, ALS ambulance inventory, we're almost there, guys. Hemostatic gauze no longer optional, and it's actually been added to the BLS inventory with PAR level of 2. Automatic cardiac compression devices. You might recall that about a year or so ago, the county said, come July 1 of 2025, everyone's going to have one of these, and here we are. So that language has been removed, and now there is an ALS requirement to have at least one automated cardiac compression device on your unit. Under dextrose, this is kind of interesting. So, I said no new medications, but I kind of fibbed a little bit. There's a modification of medication. So we previously were a D50 system using a 50% dextrose solution. In reflection of some recent research that has shown the benefits of using D10, the county is now going to update the inventory list to say that dextrose 10% with the PAR level 4 should be on all units. D50 isn't banned, though. It's now just going to be an optional item to have, which is good in the event that we might be suffering a D10 shortage. So some of the reasoning behind this, D10, a 10% dextrose solution, is far less concentrated than D50, which is good because if you unfortunately have extravasation when you go ahead and administer it, the injury to the surrounding tissues is far less when you're dealing with a less concentrated solution. It's also better for patients when you administer dextrose and it's a very high concentration. The fluctuations that body goes through in response to that D50 solution are quite severe. So when you administer D10, the body doesn't have they're not going through such a roller coaster of osmolarity shifts in their blood. So D10, just as efficacious with less of a side effect profile. So the county's making a move to shift into that. And with that, we see a PAR level 4 now being required and D50 moving to the optional items list. Also noted is Ringer's lactate solution. So this is great in times of IV normal saline shortages, right, to have Ringer's lactate. So Ringer's lactate is now going to be listed as an optional item for units to carry. And an important note, though, that with the exception of amiodarone and ketamine, medications listed under P401 may be infused with Ringer's lactate solution during periods when normal saline is in shortage. This substitution shall be on a one-for-one basis. And for example, if the protocol advises for 250 mLs of normal saline, you can replace that with 250 mLs of Ringer's lactate. So with the exception of amiodarone and ketamine, which per manufacturer, it says you must mix with NS, with the exception of those, all of the other medications in our system can be mixed with Ringer's lactate, which is nice to have on deck in times of NS shortage. So Ringer's lactate's now being added to the optional items list. You might recall that I had mentioned that the nasogastric tube guidance under the skills list has been expanded. So too, the ambulance inventory is being asked to carry more sizes of nasogastric tubes. Also, an important note that's put on there for ambulance inventory is that any patient care inventory, so any item, any device, any medication not listed in this protocol must have LEMSA approval prior to use. Agencies must validate training, education, and QA reporting processes for all approved optional inventory items. So an agency can't just add something to their cache of inventory. They have to go through proper LEMSA approval to do so, and that's just listing that here. Policy updates, we're not going to go through each one of these. The good thing is if you've been paying attention, you will have captured what's happened with all the policy updates. For example, the updates for S402, that pre-hospital termination death, are simply a reflection of what we already talked about with those new traumatic cardiac arrest algorithms. So the language in the policies has been updated. Same thing with S412, the pre-hospital treatment and transport of adults. That's all been revised to reflect the new S100.2, which discusses whether BLS or ALS is a more appropriate transport option. So we're not going to go through these line by line, but just mentioning that these are the policies that have revisions that are effective July 1, with many of them just going to be now listing what we've already talked about with all the previous protocol updates. And that's it. See, I told you this is not going to be that bad of a year. I'm really excited how short this was. But I look forward to seeing how these new policies and protocols take effect. Like always, we will circle back once we have some cases under our belt to see what may have changed for next year. Again, I'm Jenny Farah. So good to meet with you all again for our protocol and policy update.